Good morning, Nigeria. When I signed off on radio, if I'm not mistaken, it was mid-month in December, I did say that I'll be back with this Monday morning weekly fintech show on the 12th of December. And yes, indeed, the fintech show returns for the 2026 season next Monday. That would be 12th January. It's also the reason why you would not hear Asuquo with me on the show today. So why am I here on the 5th, 1 week before advertised? Well, I'm opting to spend my first minutes on radio in 2026 to address a health matter, one of serious concern, at a time when its prevalence is reported to be on a steady rise. So hello and welcome to this special broadcast today. I'm Femi Obong-Daniels. It's such a delight and a great pleasure to be here on the show and live on radio with you. We're streaming live on Facebook and on YouTube. Find Nigeria Info. You can't miss it. So let's begin. Over the past few days, about a week and a half or so, many of you may have seen and heard the conversations following the passing, the demise of Esther Mensah, fondly called Auntie Esther on social media. My attention was called to that conversation. Remember, it was even my wife who had called my attention to it. And I followed some of the conversations, some of the discussions. Yes, social media has been loud, emotional, and divided, largely focused on who or what to blame. Now, at the heart of much of the online conversation was blood transfusion. And that got me thinking and wondering. Ultimately, cancer is a big, big deal. Some have even been on record as saying there's been an explosion of cancer in the last half a decade or so. Some people even say post-COVID, cancer literally has gotten out of hand. So this morning, we want to slow the conversation down and ground it in medical fact. What are the facts? Well, chief of these facts is this. Esther Mensah, or Auntie Esther on social media, was living with stage 4 cancer. That matters because according to medical experts, when cancer reaches that stage, medical care is no longer about cure. It's about comfort, about symptom management, and quality of life. I lost my dearly beloved dad to late-stage cancer 3.5 years ago in 2022, so I can relate. But don't take my word for it. I'm a stark illiterate in this field. But those who know me know that when in doubt, I ask those who know. And you'd hear from such credible sources in a moment. Questions are, is there a cure for advanced cancer? Why do so many cancers get diagnosed so late? What does stage 4 actually mean? And what should the public really understand about cancer survival? Well, to help us unpack this, all of this, responsibly, we are joined this morning by medical experts, and if you're fortunate enough, media professionals who can help separate fact from emotion. Let me start by introducing Dr. Marcus Inyama Asuquo. He's the chief consultant hematologist. He's a chief consultant hematologist at the University of Calabar, the professor of hematology. He's a member of many professional associations and has sat on many academic and professional boards. Dr. Marcus Inyama, Asuquo, good morning to you. Thanks for joining us today.
Good morning.
Great pleasure having you in this conversation. Thank you very much for joining us. Also joining us is Dr. Joseph Udosen. He's Chief Consultant General and Breast Surgeon. He's the head Department of Surgery, University of Calabar, and of course the University of Calabar Teaching Hospital in Calabar, Cross River State. Dr. Udosen, thank you very much for joining us this morning, sir.
Good morning, sir. I'm pleased to join you.
Such a fine pleasure to have you with us. So, sirs, let's start with the medical reality. We're trying to understand stage 4 cancer. At that stage of cancer, if you could enlighten us, maybe I should start with you, Dr. Udosen. What does treatment realistically aim to achieve at this stage of cancer? And is blood transfusion a life-saving cure at this stage?
Thank you very much, sir. Although I joined late, I didn't get your name.
Oh, my name is Femi Obong-Daniels, sir. Just call me Femi.
Okay.
Yes.
Femi.
Yes.
But you are bearing Obong. That's from Asuquo, Cross River origin.
Yes.
You are bearing
Yes, my father is. So I'm from there too. My mother isn't.
Thank you very much.
Yes, thank you.
Okay. When you say stage 4 cancer, that's in oncology terms is an advanced cancer that is at the end of the realm. It is end stage cancer. So the aim of treatment at that stage of cancer is not for cure. It is palliation. It is the treatment aims to make life more bearable and probably help to make you prepare for the eventuality, because once it is stage 4 cancer, it is most times the cancer, the disease will take its course on you, except you have what we call remission, which is sometimes very rare. So stage 4 cancer is an end stage disease, and usually most of the treatments will not abate it. It's only to palliate, make life more comfortable, probably reduce the complications and other aspects of the disease. And in terms of blood transfusion is not a treatment for cancer. Blood transfusion cannot change the outlook of cancer. Blood transfusion is just one of the tools we use sometimes in the management of cancer. It is not a curative treatment. It does not cure cancer. I don't know whether I've made my point clear.
Very clear, sir.
I will leave it like that until you ask for that.
All right. Thank you very much. And you made clear that at stage 4, cancer is more about hospice care, trying to make the patient comfortable to the very end.
Yes.
Well, Dr. Asuquo, I'm wondering, I'm trying to put this, put some data figures behind this. What the chances are in early stage, what it is like in late stage. The question I'm trying to ask is whether you can further explain the difference in survival outcomes between early stage and late stage breast cancer. Well, I think when I go to breast cancer. I think I'll probably talk more to Dr. Udosen, being a breast cancer, a breast surgeon. Maybe I should stick with you. So
no, you're not entirely wrong.
Yeah.
I treat cancer too.
Oh, beautiful, beautiful. So,
Yes.
Tell us what the difference in survival outcomes is between early and late stage breast cancer, and why timing matters so much.
Very good. A cancer specialist will be very happy to see patients who come at an early stage, because therein you are able to intervene in the treatment and get good remission, not partial remission. I mean remission that the person can stay disease-free period can be long enough, and you can give that person 5 years survival, sometimes 10 years. I have patients I've treated for blood cancers, and some of them are 10 years, they are still doing well. Some sent me a New Year greetings recently. That is the aim, but that can only be achieved at an early stage. Whereas, just like Dr. Udosen has said, in the late stage, in the stage 4 disease, when it has already spread to all other organs of the body, these are the organs that maintain life. Once they have been hit by these cancer cells and hijacked, as it were, it is difficult to eradicate completely, and this patient can be moribund throughout the period of your treatment, and you will not get the kind of optimal care you would output or outcome that you would have expected. So the difference is very clear between early diagnosis and late diagnosis. I'm sure Dr. Udosen will say more, especially when it comes to applying it to breast cancer. Thank you.
Thank you very much. But the question in my head now is, why so many cancer cases in Nigeria and similar settings get diagnosed at very advanced stages? When it came to our attention that my father had multiple myeloma and all of that, it was already in a very, very late stage, and we had been treating all sorts of things. We didn't see it. We not even his primary health care givers didn't catch it early on. So I'm wondering, sirs, Dr. Udosen, why is it that it is so in Nigeria, where cancer is usually caught in late stage? Dr. Udosen, can you hear me?
Thank you very much
Okay.
for the question. Very, very interesting question. And it cuts through to the hearts of cancer management in Africa. Unfortunately for us in the sub-Saharan region, more than 70% of our cancer cases are diagnosed at late stage 3, stage 4 disease. So hardly do we, maybe like 10 to 20% is diagnosed at early stage. That's a fundamentally obscured and a very bad situation for us. What are the reasons for this? One is we don't have enough of our patients are not aware of the symptoms of early breast cancer. For example, let me use breast cancer. Even when they are aware of it, they don't take it serious, because breast cancer presents as a lump in the breast. And that lump is painless. Painless. And when something does not pain you, you don't pay attention to it. So it can be there, and they can say, well, I felt it, but it's not disturbing me. And they don't come for checkup. We don't have a social security situation where people can just walk to the hospital and be checked without having to pay so much. So we don't have that kind of insurance policy that enable us to do mass screening of all our women and indeed men, because 20% of breast cancer also occur in men. So we miss it at that point. And then when it starts, There are a lot of misconceptions about treatment. Somebody will say, you have breast cancer. Oh, I read it in the internet. You should do this, you should do that. GNLD drugs. Some of them will go and take those stuff at the early stage, and the thing will spread out. The thing will conflagrate. So we have poor outreach to women. So what we need to do is public enlightenment, and that's where you come in. A lot of enlightenment needs to be done to change the narrative so that people can present at early stage. When you come at stage 3, stage 4, the outlook is usually dismal. And then you hear people say, I went to the hospital, they cut my breast, and the patient died. That is not the true picture. If you come early, we don't even need to cut your breast. We don't even need to, we just remove the lump and treat you, and you are okay. Because we have good drugs. We have drugs that can take care of the spread of the disease. We have tests that we can do to tell us the exact type of cancer you have, and the medicine we can give targeted to the particular cancer you have. All these are useful when you come early. So what we are seeing, unlike in the Western Hemisphere, they have reduced the mortality of cancer because of all these strategies, early presentation and mass checkup, mass screening for this cancer. So we have a fundamental problem of enlightenment and screening. Those two basic pillars are missing in our environment. And that is why our patients present late. And ignorance, very important. So we need to do a lot of work. Not just medical people, not just oncologists, everybody that is involved in the cancer space. We need to do a lot of work to change the narrative. Thank you.
Let me stick with you for a moment, Dr. Udosen, because you did mention what poor maintenance medication can do, can conflagrate, can intensify, or can spread it. There are some who feel that sometimes through the methods of detection can be problematic. We've read about the potential in some cases. I don't have the expertise to determine that biopsy, for instance, which I believe is a method of checking to make sure you don't have cancer, or to detect if you do. But some have been on record as saying, sometimes too, biopsy itself might more like fast track the growth of the tumors in the cells. Can you speak to that, sir?
Okay, thank you very much. That's a very topical issue. So what we do here is, depending on the stage you present, if you present early, we do what we call ultrasound-guided biopsy, or when you can afford it, MRI-guided biopsy. We use machine to detect the lump, the actual lump that we can identify, and use ultrasound to pick from that lump. And it is more specific because we have located it. So the level of what we call false positive results will be less. So that's what we tend to do now. We tend to go straight to the lump. Yes, you are right. Sometimes when you do a biopsy and you forget about it, you can open a potential channel for spread. But that is why.
Hello, Dr. Udosen. Oh, goodness me. It would seem Dr. Udosen has some connectivity issue. I hope he rejoins us in a little bit. While we await that, let me come back to you, Dr. Asuquo. Doctor,
we also say,
okay.
as soon as you do the biopsy and you get the result, treatment should be started. Whatever treatment, keep that lacuna. You don't keep that space.
All right. Thank you very much, Dr. Udosen. We've been able to catch up on the end part of what you were saying. So let's go to metastasis. When cancer has spread, or as you experts say, when it has metastasized, what should families and the public understand about prognosis and care goals at this point? Dr. Asuquo.
Okay, thank you very much. I thought I would also add something to what Dr. Udosen said in regards to our health-seeking behavior in our country that fuels this surge in cancer. But let me take this one first. Once metastasis, that is, from where the cancer started, it has moved, or some of it can be through the blood, it can be contiguity to other parts of the body, and many of these cancers have a predilection for certain sites. Now, there are certain organs of the body that are very important to sustain life. The brain, the liver, the lungs, and once all those organs, the kidneys, once they are infiltrated by tumor cells, that's cancer cells, and they too are down, it becomes difficult. That's why when we see widespread metastasis or to the organs, then the treatment becomes difficult. The reason is that once treatment is initiated, it is these organs that will help the patient to be able to withstand and even metabolize the medication or whatever intervention you are going to introduce into the body. Whether it is radiation therapy, whether it's going to be chemotherapy, whether it's going to be targeted therapies, the liver will be involved, the kidneys will be involved. If these organs are down because of metastasis, then the problem is compounded and it makes survival or the overall outcome to become very poor. The question you asked, like multiple myeloma, which is in my own line of specialty, multiple myeloma is a very slow growing tumor. And as such, it can be in the human body for over 12 years from the time it started that the person will not know. It is only when people are able to go for checkup, and they check up with people who have high index of suspicion that it can be detected on time. Most of the time, it is detected late. But having said that, it is a better form of blood cancer to have than most other ones like acute leukemias, as it were. So when patients go, Dr. Udosen talked about breast cancer. When patients go, their first point of call is to a patent medicine dealer. He gets 2 or 3 capsules for whatever problem he has. And he keeps on going there. If it becomes too much, he goes to a lab and they tell him he has typhoid or malaria and they will treat him for both. He goes, but what is going on? The cancer is still going on. And then the next one is to go to his pastor, and the pastor will pray for him. Last week, I just had a friend who just called me about his wife who has developed breast cancer, but she's been keeping it away. And the pastor has been giving him honey to go and rub on the tumor. Now it has opened up and it's fungating. That's when the husband got to know. So the health-seeking behavior practices of our people is faulty. This is where the media comes in to help. And there's a lot of NGOs that are into this program now to help our people to say, no, let us change the narrative. You can do better and you can survive. If this, our friend, Auntie Esther, had sought help earlier and it was detected on time, we wouldn't be sitting down here to talk about her demise. Thank you.
Thank you very much for that. I can see Dr. Udosen has been trying to join. He's joined us back now. I would also need to acknowledge the presence in our midst. I'm not sure if it's convenient at this time, but he's present in this panel, a retired media professional, one one of the people the likes of us looked up to in our early years, one of those people who got us interested in media and who's been retired for quite a while now. If he'd be so obliged as to share his thoughts as a former media professional, because I'm going to the question of media, particularly those of us in this profession. Before that, though, I want to touch on misinformation. What role misinformation, whether cultural, religious, or social media driven, play in delayed diagnosis and poor outcomes? We will come back to elaborate on the power of early detection in changing outcomes in a little bit. But in the meantime, yes, if it is convenient for Mr. Ereyemi to say hello, we would appreciate that. And if not, we'll understand. So maybe, Dr. Udosen, welcome back. Connectivity played a fast one there. So maybe I should stick, while I give you time to properly follow, maybe I should come back to Dr. Asuquo if I cannot get Mr. Ereyemi. You mentioned something about people going to their pastors to pray for them, religious leaders and all of that. But there is also a lot of misinformation, as even Dr. Udosen had hinted at initially. What role does such misinformation play in delayed diagnosis and poor eventual outcomes?
The role is that there's usually a delay because cancer is cancer. There's no harm in going to a pastor to pray for your well-being, for your spiritual well-being. But there is harm if you now rely on that and you don't go to the hospital for your medical checkup, for your treatment to be effectively carried out by the medical health sector. To give you a scenario, I had a patient with blood cancer. We made a diagnosis. This young man did not have the money. And I had to appeal to somebody to donate money for his treatment. Of course, money was donated. We purchased they purchased the medications for the cancer to be treated. Only for the boy to say he wants to go and seek his pastor's deliverance first before coming. And he went to the church. Never came back because he died in the church. So such narratives are many in practice. So there needs to be a way of separating spiritual. Well, you will not separate it like that, but let there be a synergistic, not disconnecting kind of relationship between patient and pastor and the healthcare. Let there be a synergistic approach. Go to your hospital. We'll pray for you that whatever you're doing will work. It helps that way. So when that is not done, people spend so much time either in faith healing or whatever is done, so that by the time they now say it is getting late, they contribute to patient presenting very late. That's when they say, look, it is beyond us. Go to the hospital. At this stage, the patient cannot walk. They are carrying the patient to the hospital. And then they will now later on go and say, it is not hospital treatment. I told you that when you go to the hospital, you will die. But nobody will say that the patient was brought in at a moribund stage. I'm sure Dr. Udosen has more to say on this because he too faces the kind of challenges we all face as cancer caregivers.
Not a doubt. Dr. Udosen, do you want to follow through on that, on what Dr. Asuquo just said?
Oh, of course, we see it a lot. The narrative is so much. And unfortunately, even well-educated people, professors in different cadres, in different fields, still do the same thing, still fall into the same trap. And you begin to wonder what education they had that they cannot decipher the difference between spiritual and physical. You will see a professor, I saw a lady, a professor in the university with cancer, and we advised for treatment and everything was agreed upon, and she left. And one charlatan somewhere told her she would need some herbal things and some, spiritual repairs and all that. And she went, and by the time she came back after 6 months, the cancer had spread everywhere. There was nothing we could do at that stage. And then, if you now take such a patient in, they will now say, oh, she came to the hospital and they treated her and she died. Meanwhile, when she came and you wanted to offer her the best treatment, she never wanted. So we have all those scenarios. And that is why I'm saying it is not one-off kind of media attention or public awareness. It should be a continuous process involving children in secondary school, involving children, people in the university, everywhere, market women. It should be overwhelming, and it should be government supported so that this message get down to the grassroots, to the people's mind, to know that the earlier you start tackling cancer, and the better. And as you know, what is early, and that is why we have to give the symptoms, all those symptoms. For example, in breast cancer, once you feel alone, no matter how small, gets to the hospital for confirmation.
Thank you, Dr. Udosen. Your connection. Okay, could you repeat what you just said, sir?
I said, once you feel alone, for example, in breast cancer, no matter how small or painless, get to the hospital for confirmation.
Okay. Thank you, Dr. Udosen.
Once people start getting in, people will start knowing the reality of what we are talking about.
Thank you, sir. Your connectivity is not as strong as it was previously, but we managed to get the bulk of what you were saying. You did allude to even educated people seemingly being little informed about the situation. You did talk about a university professor who had presented with cancer, who was supposed to go straight into treatment, but wanted to go to her spiritual leaders and all of that. And if I'm just going to go back to what Dr. Asuquo had also said, there is a place for faith. Faith and hope are connected in some way. But people should know the difference between the spiritual and the medical. And when it's a medical problem, you have to quickly, especially as relates to cancer, because of early detection, you've got to get medical assistance pretty quickly. Which brings me back to that issue of early detection in changing outcomes. I saw a report somewhere that says when it comes to outcomes, there is literally a 98-99% chance of a positive outcome when cancer is detected early. But in best case scenarios, when it's detected late, the best case you have is 28%, which doesn't look that's literally 1/4. The odds change dramatically when not caught early. So how powerful is early detection in changing outcomes? And I know because you've touched on it before, I want you to add this part. What screening methods actually are the most reliable that really save lives? So that if people are talking to the healthcare givers, they can say, oh, I heard this is a method. Are you considering it, sir? If it is not an option on the table for them. Dr. Asuquo,
Well,
yeah. Okay, go ahead, Dr. Udosen. Yeah.
Okay, thank you. I would only speak more on breast cancer and maybe colorectal cancers. When we talk of breast cancers, we have many screening modalities to help us to detect it early. One of them is simple breast self-examination, which we teach our ladies to be able to identify lumps in their breasts. And then we proceed to clinical breast examination, where they come to the hospital. Sometimes we do outreaches, like during cancer week. People will come out, and then we will examine them in an outreach setting, identify lumps, and then proceed from there to do ultrasound scan. So ultrasound scan will now locate the lump, and then we will now move from there to biopsy the lump. Biopsy could be what we call excisional biopsy. You remove the whole lump and go and test, or incisional, you remove a part of it to go and test. Part of this incisional biopsy also includes ultrasound guided biopsy. And it can even proceed to MRI or other bigger modality guided biopsy. So the bottom line, the fundamental thing to use in getting a diagnosis, both for medical legal purpose, is a biopsy. You must do a biopsy and get an histological confirmation before you can even proceed to remove a woman's breast or any other breast for that matter. You cannot rely fully on your clinical diagnosis. Neither can you rely fully on your radiological investigation if you do not confine it histologically. So that's why histology is the bedrock of our diagnosis. All we try to do is to make that histology less invasive as much as possible. But we must get a tissue diagnosis. The tissue will help us to know the type of cancer and the special type. There are different types of cancer. Which one do you really have? And that will be tailored, the treatment will be tailored to the type of cancer you have. So that is how it works. It moves from the basic to the esoteric. So that is how it works.
Thank you very much.
That is how we do it.
Thank you very much, sir. So you had mentioned that men tend to overlook the fact that breast cancer is something that men themselves suffer. I'm sure some people are hearing this for the very first time today, that a man can have breast cancer. You describe the early, easy checks that women are advised to do. I'm a media professional. I really have never thought that I should check for lumps at all. The process for men, is it similar to what you've just described in the case of breast cancer for women? Is it the same for men?
Yes. Fortunately for men, because they don't have big bulky breasts, once a lump appears in a man's breast, it is easily detectable. Once you wake up and you wear your white singlet and you see a bulge on one side bigger than the other side, you must go for checkup. So men's own are easily detectable, but they are usually much more aggressive than women's, because the breast does not have space for it to grow. Before you know it, it grows into the chest wall. So men, in fact, right now I have like 5 men who have breast cancer at different stages. Some of them will still do the same operation we do for women, remove the total breast and even the tissue around it. But I want to allude to one important fact. A husband is the best person to detect a woman's lump, because women don't know how to really examine their breasts. But if a husband is trained on how to detect lump, he will be the first person to detect his wife's lump. I have had patients that came, the husband said, "Sir, I felt this thing in my wife's breast. Please, can you check for me?" And it turned out to be a lump. So one of the things that we need to put across is let the men be involved in the women's breast health. Let the men be involved in examining their women's breasts, even if they are at girlfriend level, because breast cancer is ravaging younger women even more rapidly now. So initially we used to say it happens at late 50s, but now go to 20s, 30s, we are seeing breast cancer. So let the men be involved in examining their women's breasts so that they can detect this lump better and report as soon as possible.
Just sticking
That's
with
the message I want to pass.
Thank you. That's an important message. The question that will naturally follow is, how do men learn? Where do men go? How do they practice?
That is what I'm talking about, public enlightenment and training. We need to open up the space. Media practitioner must do much more for cancer. You must bring out the conversation. You must generate it. You must find a way that we can teach. We used to teach breast self-examination to women, but I think men should also be taught how to examine the breast so that they can detect it earlier in their women.
All right.
So that's where everybody comes in. It's not a single thing. They have to be trained. It's not something they will know on their own. They have to be trained.
This is food for thought for men, particularly husbands. And if there is a woman in your life that you care about, you probably want to go. I would suppose that a man can walk into any teaching hospital and ask to see an oncologist or a hematologist or a specialist in breast cancer to just ask simple questions regarding how can I test. I do not know whether there are YouTube videos because these days young people learn everything online. Are there resources online that could help somebody who might not feel inclined to go to a physical professional?
I think Dr. Yaba can answer that because it's into it.
Dr. Inyama?
Into what?
Dr. Inyama Asuquo.
There are a lot of online documentations that teach. But we have to be careful because very few of them are able to demonstrate that properly so that we don't go to learn something that we say, oh, but I learned this and eventually the person still gets breast cancer. There are a few of them that do it. So if you want to take any online video to learn how to, let it be the one that is sponsored by a professional body that will really demonstrate it adequately in such a way that we'll be able to miss nothing when we begin to practice it on ourselves.
Thank you. I would just hazard a guess that it might be useful to go with Madame to a specialist while they examine her. It might be an opportunity for you to say, please, could you teach me or could you teach us how we can check this from time to time ourselves so that we can catch it early? And some people haven't gone to check for anything for years. They have no idea what might be growing in their body. So this information is very critical. But I'm tempted to ask, how about biology? Are there biologic characteristics of some cancers that tend to conference unfavorable outcomes? Are there certain things to look for up to regarding, maybe your family history, but more than that, whether you are a plus size person or you are skinny or whatever history you have? Are there things to consider? And please feel free to enlighten us on this if you are with us, Dr. Asuquo. And then Dr. Udosen, please feel free to add to it.
Okay, thank you. So every cancer will not present the same way. The outcome may not likely be the same because of the underlying biology. Like breast cancer, for instance, there are favorable and unfavorable biology, which Dr. Udosen is going to talk about. So when you have an accumulation of unfavorable biology, whether you were transfused, you are not transfused, whatever treatment, the outcome is usually very, very dismal. And you look at it, no matter what you do, the person will still die, except maybe at very early diagnosis. In all tumors, it is the same. So we want to let this come at the back of our mind of the discussion that is going on in social media right now, that anti-Esther, but nobody knows. If anti-Esther had triple negative tumor, it would have been difficult. She attended one of the very good and excellent cancer center in the country. So I'm sure they know what they were doing. So it couldn't have been say blood transfusion, as it were. But the late stage and maybe unfavorable biology and so many other things could have contributed to her demise. Unfortunately, we have left that aspect, and we are concentrating our discussion on transfusion. We should look at how we can help people to come to carry out self-check, and early diagnosis should be encouraged all around the country, not only for breast cancer, because young people are coming down with so many cancers that used to be for adult and very old people, but they are coming down. Colon cancer, not talk about cervical cancer, which is a curable disease, which if people do what ought to be done, go for screening and all that, there's going to be a better outcome, which the Western world have achieved. And there's a decline in the demographics of all that now. But we are on the rise, steep rise in the incidence case. We need to look into this.
Thank you for that, Dr. Asuquo. The report I saw on the anti-Esther case was that by the time it was detected, the cancer has spread from the breast to her armpit. And dear sirs, if you could speak to that, what that means, that the breast has not been, the cancer has not been confined to the breast, it has gone to the armpit. What are the chances at that stage? And if you could just add to it, gentlemen, sirs, have you yourself had any instance in which you have treated a breast cancer patient without blood transfusion? Maybe Dr. Udosen wants to go first.
Thank you very much. Once a patient is diagnosed with cancer, even at early stages, it is believed that it is already a systemic disease. What do I mean by that? It means small parts of it may have already spread to all over the body, but we may not have been able to detect them at that stage. So once a cancer leaves the breast and enters the armpit, it's already an advanced cancer. It's already an advanced cancer because it has left the breast tissue and has entered the armpit. It may have also gone beyond the armpit if we have better investigative tools to look for them. But like I said in my opening remark, blood transfusion is not a treatment of cancer. Blood transfusion is just an ancillary thing that we do when we are treating cancer and the blood of the patient, especially probably when we want to do surgery and we need to remove so much tissue, we may use blood transfusion. But most times we hardly use blood transfusion because before you do surgery, you will have optimized the patient such that you will know about, you will be able to say, oh, this patient may lose like this. Let me bring the blood to a level that even if he loses that, it will not compromise. Secondly, we have other things that we use. Blood products, blood enhancing agents, something like EPO, erythropoietin, can be given to stimulate the blood. So most of us do not even like blood transfusion because blood transfusion on its own has its own problems. So, but that does not, I am not saying that we don't use blood transfusion in cancer management. We do use sometimes when it is absolutely necessary. But it is not a treatment modality. It does not treat cancer. It is not a treatment modality for cancer. That is what I'm saying. It could be used in ancillary setting, maybe to help in bringing up blood or whatever you want to do if you don't want to take the painstaking way of rebooting or regenerating the blood itself, or you don't have the time to do all that. So that is what I need to say on that. Blood transfusion is not a treatment modality. Anybody that has advanced cancer, like I said from the beginning, depending, like the question you asked, depending on the biology, there are some cancer you have that if we say a 2 positive disease, it's a very aggressive cancer. That kind of cancer you use more than 12, 15 million to treat. The chemotherapy cycle is more than 18 cycles. So those are the cancers even ordinary patients cannot afford to treat. They have to look for help. So we have different kinds of cancer. We have triple negative cancer, which maybe that's what it has. Very aggressive cancer, especially when it occurs in young people. You give everything, the cancer does not respond. So we have things like that. It's unfortunate. There are some that have good outcome. If you have estrogen receptor positive cancer, those ones we can treat you and we give you some drugs, tablets. You take like 2 to 5 years and you're okay.
All right.
So they have different.
Thank you very much, Dr. Udosen. We were losing you again towards the tail end of that conversation, but the point is very clear. Let me give Dr. Asuquo the last words. Is it possible to treat, transfuse a patient and the patient still dies? And back to the questions, sir, have you had experience treating a cancer patient bloodlessly yourself? Dr. Asuquo, are you with us? Yes.
Okay, yes. Yes, I have. I've treated multiple myeloma without blood transfusion. And the patient is still alive till today. So there are people who have had cancers and they're being treated, they've been transfused, they still die. And there are people who have kind of had cancers, they've been treated without blood transfusion, they are still alive. The underlying cancer, therefore, the underlying factor for survival is not the transfusion, but some other thing that is not known to the public who are making the social media commentary that we are seeing with regards to this unfortunate incidence of anti-Esther. So yes, it is possible. Patients do get treated, they are transfused, they still die, and people, there are people who are still being treated without blood transfusion that are still doing excellently well. In fact, there is a lot of cancer survivors today in the breast cancer space who are doing well, excellently well. Many of them were not transfused.
Thank you very much, sir. And as we wrap up this conversation, one thing is clear. The real issue is not blood transfusion. It's late diagnosis. We've heard that when breast cancer is detected early, survival rates can be as high as 99%. When it's detected late, options become limited and the focus shifts from cure to care. And this is why how we talk about these stories matters, especially on radio, especially on social media, where millions are listening, learning, and forming opinions. So instead of amplifying controversy, we can amplify awareness. Instead of speculation, we can share science. And instead of blame, we can promote screening and early detection. If Esther Menster's story, Auntie Esther's story, leaves us with one lesson this morning, let it be this: early detection saves lives. Talk to your doctor. Get screened. Encourage someone you love to do the same. Thank you very much to our guests, Dr. Marcus Inyama Asuquo, Chief Consultant Hematologist, member of many professional associations, who sat on many academic and professional boards. We appreciate your time, sir. Also, Dr. Joseph Udosen, Chief Consultant General and Breast Surgeon, is the head Department of Surgery, University of Calabar and University of Calabar Teaching Hospital. Thank you, doctors, for your time. I highly appreciate it. And thank you to all of Nigeria for listening. And thank you for getting enlightened, taking the time out, researching, and getting medical care early. Once again, thank you, doctors. Yeah.
Thank you for having us.
All right.
Thank you very much.
Thank you very much. The news comes right up right now. And don't forget, next week, the FinTech Show returns on Nigeria Info. I'm Femi Obong-Daniels. Enjoy the rest of your week.
99.3 Nigeria Info. We are more than just radio. Subscribe to our YouTube channel at Nigeria Info FM. Check us out on Facebook at Nigeria Info 99.3. Follow us on Twitter at Nigeria Info FM and on Instagram at Nigeria Info FM Lagos for live updates as it happens. 99.3 Nigeria Info. Let's talk.